I'm Rebecca Marmore. I'm a Johns Hopkins vascular surgeon. I practice out of Howard County General Hospital. Patients with symptoms related to their carotid artery most typically would benefit from a surgery to open up the blockage in their carotid. For patients with moderate or even sometimes high-grade disease, however, who don't have symptoms, the decision-making is more complicated and is done on an individual basis. The gold standard operation for the treatment of carotid stenosis is known as the carotid endarterectomy. It was first performed in the 1950s and involves an open operation. A neck incision is made, we go down, we find the carotid artery, we remove the blockage, and then we actually close the artery up with a small patch. However, there are other techniques we use, including carotid stenting. There are two ways we're able to do a carotid stent. One of them, the traditional way, is actually from a groin puncture. So we make a small incision at the top of the leg and deploy a stent, which is a thin flexible tube in the carotid artery to prop it open. However, for certain patients, we may choose to perform what's called a TCAR. A TCAR is a procedure where we actually make an incision on the carotid artery and insert a stent directly through the carotid. The decision about what surgical technique we use to treat our patient's carotid disease is a very individual decision. It's made based on the patient's anatomical factors, prior surgical and medical history, and there is an element of the patient's medical condition. So patients who are very sick and maybe are not able to tolerate a general anesthesia are typically offered a less invasive operation. For patients who have very high lesions, up almost at the base of the skull, these are very difficult lesions to access surgically. Typically, we'll offer a stenting procedure for those patients. Carotid endarterectomy is thought to have the lowest risk of peri-procedural stroke. We typically quote the risk of stroke somewhere between 1% and 3% for our asymptomatic patients. Patients who have symptoms related to the carotid disease do have a higher risk with surgery. TCAR, the surgery where we actually deploy a stent directly through the carotid artery, is thought to have a stroke risk equivalent to that of carotid endarterectomy. So that's been a huge revolution in the vascular surgery world, where we have a minimally invasive technique to treat our patients' carotid disease that offers an equal risk of stroke as the gold standard operation. Transfemoral carotid stenting, where we actually make that small incision on the patient's leg, does incur the highest risk of peri-procedural stroke and is typically only offered in very select circumstances for our patients. Typically after a carotid surgery, we observe our patients overnight in the intensive care unit, where we pay very close attention to their neurological exam and keep very strict control of their blood pressure. The vast majority of our patients will actually go home the day after the carotid intervention, whether that's a stent or a traditional open surgery. We typically see our patients about 2 weeks later for a wound check, and then I'll typically get an ultrasound, which will serve as their new baseline for their carotid disease about a month to 6 weeks after their surgery. One of the things I love best about being a vascular surgeon is developing a longitudinal relationship with my patients. And when patients have had a carotid surgery, I will surveil them for the rest of their lives. We start with more frequent ultrasounds to make sure that their arteries are doing well. And then, if everything's going good at a year, we'll typically space our surveillance out to an annual ultrasound, where we'll meet, we'll check in, we'll review their results, and I also get to hear about how their lives are going and how they're doing.